win.
Hello, welcome to the July Skillz meeting. You'll notice a new theme for the next few Skillz meetings. We're going to be focusing on clinical practice guidelines for the most common diagnoses we tend to see. We're working on some handouts that'll work with our patients and with providers to summarize those guidelines. And really the theme is that we should all be standardizing our treatment to give the best evidence-based treatment to our patients. Does that mean we do the same thing to everyone all the time? Of course not, but we also shouldn't be practicing too far outside the scope of what has been proven to work for people, all right? So we're going to start with hip OA, and hip OA is very common. We treat it regularly, and it can respond really quickly and really well to treatment. So the guidelines are pretty clear. You'll already find the information I'm talking about in our clinical library. So it's all there for you. We're working right off those clinical guidelines. This is just a summary of them. So when taking a history, we want to look for things like the risk factors for hip OA include age, hip developmental disorder, and previous hip joint injury, things we're covering in our subjective. To diagnose or classify hip OA as well, reports of pain in the lateral or anterior hip with weight bearing, adults greater than 50 years of age, limited passive range of motion in at least 2 of 6 directions, and reports of morning stiffness that's resolved in less than 1 hour. All things that are coming up in our subjective. All right. Another clinical prediction rule to diagnose hip OA that was studied says self-reported squatting as an aggravating factor, active hip flexion causing lateral hip pain, the scour test causing hip or groin pain, active hip extension causing hip pain, and passive internal rotation less than or equal to 25 degrees. So those are some things we're looking at throughout our exam. Now let's dig into when we start moving the patient around even more. What else can we use as our special test, right? Kevin here is our model. Thanks, Kevin. One thing we can look at really quickly would be our Faber test, right? Quickly do that, see where the symptoms are, but qualify it. 0 to 10, how uncomfortable is that? We can look at our scour test, 0 to 10, how uncomfortable is that, right? Providing a little compression, rotate outward, rotate inward. But have the patient qualify it. 0 to 10, what is your pain during those things? We would also ask, 0 to 10, what is your pain with stairs, with squatting, and with walking? And chances are those are going to be some of the goals your patient has, whether you're using photo or you're ending your examination by asking, what ultimately are you here for? What is your expectation for treatment? I imagine it revolves around something that requires standing, walking, squatting, or bending to the floor. All right, so as far as treating it is concerned, we need to know the main hip mobilization. So that's what I'll jump into now, and then we'll spend the rest of the time practicing, because we know from the waggle feedback we've gotten that people want even more practice, even less videos. All right, so the things the evidence shows works is manual therapy, mobilizations, in addition to exercise, and in some cases for hip OA even more than exercise. There's great evidence for long axis distraction, which, again, you could call it long axis distraction, and it's essentially an inferior glide too. What we want to do is a little bit of flexion, a little bit of abduction, a little bit of external rotation. That's the loose pack position. I tend to use this secret hand grip that only the pros know. And as you lean back, right, come, and don't be shy to give a quick grade 5 thrust, right? Check the patient in between. Each time you do it, I tend to move into more internal rotation, more abduction, and more extension, bringing them into their limitation. Oscillate right at end range, but don't be shy to give a good grade 5 mobilization. When you do that, you'll get immediate improvements in hip internal rotation. From there, if we use our belt, and for anybody who's tried these, it's worth using the belt. These are mobilizations we absolutely have to be proficient in for hip OA. Because from this direction, we can perform a short axis distraction out to the side. We can then bring him into more of his limitation where it's painful, perform the same mobilization. We can then provide a sustained mobilization and turn it into a mobilization with movement. We can then swivel down here and turn it into an inferior glide. And again, we could do lateral distraction, and we could do a mobilization with movement into flexion. All of those are going to increase your internal rotation, increase your flexion range of motion. If you find your patient is limited with crossing their leg, or limited with external rotation, or limited when you're testing that piriformis stretch, then we need a posterior lateral stretch, okay? Come over here. The easiest way to start is just with your body weight here, right? Posterior laterally, they should feel more than just a stretch. They should feel a good capsular stretch too. We can start here. If I really want to crank on the patient, I'll actually lean over, and with just a pinky, I can really put in a ton of force through their hip. And each time you test it, you're going to see immediate improvement. So there's that asterisk sign. Your patient will immediately be able to get that leg up farther, maybe even cross their leg with just a few mobilizations. Last but not least, right, so that was the posterior lateral stretch. Kevin can lay on his stomach. And then anterior, most patients are going to lack some hip extension potentially. So I like to start in the figure 4 position, all right? Rest him right there. Here's my grip, and I mobilize directly over the hip, and you should be able to feel it in the groin and the front of the hip. And you can really put a lot of pressure on somebody. In between, I'm bringing up into extension to progress. I can then perform an anterior mobilization here, or even potentially cupping around his greater troch and performing from the side. How do you know which one works better? You test it and you just ask the patient. After performing those, my two go-to stretches are this. Kevin, you can stand up. Most often, we're increasing that inferior glide to improve abduction and internal rotation, and then our hip extension to improve that stride. So I go with the basic adductor stretch, but anybody has seen an adductor stretch before. I tend to have a patient put their hand here and add their own inferior glide. So you can get that inferior glide of the femoral head. Same thing with hip flexor stretch. Have them do that hip flexor stretch, but if they're capable, have them add their own anterior glide. Patients see immediate results from this because it's like you performing their mobilization, and they feel like they're doing more than just a stretch. They can oscillate for 20 or 30 seconds, rest and repeat a few times. Oftentimes that's my only HEP if somebody's coming in with a stiff hip. Then you can layer your exercises on top of it, your clamshells, your bridging, promote hip extension, retrain gait. Then you better be getting into squats and stairs because that's what they're there for. So that was assessment and treatment of the hip, hopefully in 5 minutes. I'm sure I went a few minutes over that, but in roughly 5 minutes. Now we're going to move on to the next slides and walk you through actually practicing these. Thanks. Was that 10 minutes?